Desmopressin is the best initial therapy for both uremic-induced platelet dysfunction, von Willebrand's disease, and very mild hemophilia. Mild hemophilia I can treat with desmopressin, DDAVP, because it causes the release of subendothelial stores of von Willebrand's factor, which happens to be bound to factor VIII. The reason that the PTT goes up is because the factor VIII antigen is bound to the factor VIII coagulant. And the von Willebrand's factor is also known as factor VIII antigen. The hemophilia factor is the factor VIII coagulant. They're bound to each other. They stabilize each other. They're stored in the same place, endothelial cells. They're made in the same place, endothelial cells. The DDAVP releases both of them. Endothelial cells releasing both of these, making you stickier than ever. That's why the treatment for mild hemophilia, 5 to 10% level, is desmopressin. The treatment for severe hemophilia is to replace the factors. Replace either factor VIII or IX by using recombinant made factors. Not pooled, but recombinant. You take an E. coli, you insert some genetic material that tells the E. coli that its mission in life is to make hemophilia factor VIII, and factor IX. You could program the E. coli to make hepatitis B vaccine. You could program the E. coli to make factor VIII. You could program it to make factor IX. For all I know, you could program that E. coli to play jazz music if you get enough right genetic elements in there, and you don't have to pool the blood products. Remember, cryoprecipitate is never first therapy for anything. Cryoprecipitate is always a second or third line therapy. Cryoprecipitate is pooled blood products. It's the clotting factors from 10 people put into half the amount of volume. So therefore, you put a ton of clotting factors in a very small amount of the volume. 50% of the clotting factors from a unit of FFP in 10% of the volume in a unit of FFP. In other words, if a unit of FFP is 150 to 200 milliliters, you get half the clotting factors, but you get it in 10 or 20 milliliters instead of 100 or 200 milliliters. So it's cryo, through freezing, precipitates out those clotting factors. However, cryoprecipitate is never first or second for anything. A 26-year-old she/he comes with epistaxis petechiae, normal PT, and elevated PTT, normal platelets. The bleeding time is prolonged, the von Willebrand factor level is low, and we give desmopressin, but it didn't work, and they continue to be spitting up blood in your general direction. What is the next best step in the management of this patient if the DDAVP doesn't work? What would you do next in the management of this patient? What is the most appropriate action at this time? The answer is factor VIII replacement. Oh my God. You mean I can use DDAVP and factor VIII for von Willebrand's disease? And DDAVP and factor VIII for hemophilia? Well, believe me, it's true because factor VIII antigen and factor VIII coagulant travel bound to each other. They're made in the same place. They store in the same place. So therefore, you would only use cryoprecipitate if these things did not work. Von Willebrand's disease, platelet type of bleeding with the normal platelet count. A platelet type of bleeding with the normal platelet count. Von Willebrand's disease. Now, how did we know that this is not hemophilia? And the way that we know it's not hemophilia is that it's the wrong type of bleeding. How do we know it's not DIC, disseminated intravascular coagulation? Disseminated intravascular coagulation. First of all, DIC rarely occurs in a patient without a specific reason to have DIC. In other words, people who have DIC are not just walking down the street having DIC. they have sepsis, big gram-negative sepsis, where the gram-negative rods are activating the clotting cascade. Big deal. Abruptio placenta, amniotic fluid embolism, a snake bite, snake bites, burns, big trauma, rhabdomyolysis, hemolysis, rhabdomyolysis, big tissue damage, big tissue destruction, activating the clotting cascade. So that's one reason why this is not going to end up being DIC, because it has some sort of big traumatic tissue factor release. The other thing is DIC gives both elevations of both the PT and the PTT. Next thing is DIC gives diminished platelets, because everything is consumed. Everything is consumed in DIC. Everything gets consumed, both the clotting factors and the platelets. Now, the most specific test for DIC is an elevation in the fibrin split products and an elevation in the D-dimers. Now, when prothrombin is turned to thrombin, prothrombin to thrombin, factor 10 activates prothrombin. Okay, factor 7 off to the side here. Tissue factor, 12, 11, 9. Factor 8 off to the side here. Factor 5 over here. When prothrombin is activated to thrombin, thrombin splits off a piece of fibrinogen in order to activate it into fibrin. Thrombin splits off a piece of fibrinogen in order to activate it. Prothrombin turns into thrombin with factor 10. Thrombin splits off a piece of the fibrinogen in order to be the creator of the clot, fibrin. Prothrombin, thrombin. Thrombin splits off that fibrin split products. The fibrin split products is split off like taking the beer cap off of a beer bottle. You split off about 3% of it in order to activate the beer. How do I know how many beers you've been drinking when you hide the bottles all the time? Because I can count the number of bottle caps in your garbage can. And that tells me how many beers you've been drinking. Well, how much fibrinogen do I know has been activated? Well, I see how many of the fibrin split products has been eliminated, how many of those have been made, like the beer cap on a beer bottle. Now, that's how the clot is created. Now, why is it that we don't all become fibrin statues? Why is it that we don't all turn into one big fibrin clot? And that's because there's a system in the body that dissolves away the fibrin clot. And the system in the body that dissolves away the fibrin clot is from plasmin. Now, plasminogen is activated into plasmin. It's a precursor protein. Trypsinogen is activated by trypsin and the enteropeptidases in the duodenum into trypsin. Chymotrypsinogen is activated by trypsin. Pepsinogen is activated by the acid in your stomach. Pepsinogen activated into pepsin. Trypsinogen activated into trypsin. Chymotrypsinogen activated into chymotrypsin. Plasminogen generates plasmin when it is activated by something in the tissue called tissue plasminogen activator. Why don't we all become fibrin statues? Because we have plasmin dissolving up that fibrin clot. Activating plasmin causes the destruction, is the destroyer of the fibrin clot. And it destroys the fibrin clot into pieces of fibrin, and those pieces of fibrin are called D-dimers. Those D-dimers are the pieces of the fibrin. Those D-dimers are fibrin parts. And that's how I know how much the plasmin has chopped up and destroyed the fibrin. Thrombin activates and creates the clot by creating fibrin split products and is the clot creator. Plasmin chops up that clot so that we all don't become fibrin statues and is the clot destroyer and turns it into D-dimers. Now, why is it that we don't all bleed to death when fibrin gets destroyed by the plasmin? And the reason is there is another factor that stabilizes or preserves up the fibrin, and that clot stabilizing factor has two names. One is factor 13. The other name for the factor that stabilizes the clot is clot stabilizing factor. Who's buried in Lenin's tomb? What is the name of the factor that stabilizes the clot? Clot destroying factor? No. Clot creating factor? No. Clot stabilizing factor? Yes. It takes generally 3 to 12 hours to do this, and that's why TPA is only good for 3 hours after a stroke and 12 hours after an infarction before the factor 13 can stabilize or preserve the clot. Plasmin works on fresh clots. Plasmin is only the destroyer of a fresh clot before factor 13 has preserved it. Thrombin is the creator of the clot by making fibrin split products. Plasmin is the destroyer of the clot by making it D-dimers. Factor 13 is the preserver of the clot, making it so that it can't be destroyed by plasmin. Here we go. Ready, ready, ready? Samajh ka hai? Creator, preserver, destroyer, creator, preserver, destroyer, Brahma, Vishnu, Shiva. There it is. The world is a mandala. Earth is crammed with heaven. Every tree is a burning bush. Those who see it take their shoes off. All the rest can at least eat the blueberries. That's Elizabeth Barrett Browning. Earth is crammed with heaven. Every tree is a burning bush. Those who see it take their shoes off. All the rest at least can eat the berries. There we go. Fibrin split products, D-dimers. The treatment for DIC is simply to replace the factors. Replace what? Replace both the platelets as well as fresh frozen plasma. To replace the factors. Now, some of you in your basic sciences might have once been told to give heparin to people who have DIC because heparin will interrupt the clotting cascade. That's a nice idea, except people don't present when they're clotting. They present once the clotting factors have been consumed and they're all used up and they're bleeding. Ready? Don't give heparin to people who are bleeding. It destroys them. I'm melting! Don't give heparin to people who are bleeding. Giving heparin to people who are bleeding would also be known as physician-assisted suicide. Don't do that. That's bad. That's bad. Or as we like to say non-judgmentally, evil. Don't do it. Don't give heparin to people who are bleeding. DIC, both the PT and PTT are up, the platelets are down, positive fibrin split products and D-dimers replace the clotting factors, particularly if they are bleeding. You see, things that give an elevation in both the PT and the PTT are relatively rare. I know that you may think that there are a million things that elevate the PT, PTT, but there's not a million things that elevate the PTT. There's about 3 things that elevate both the PT and the PTT. DIC, liver disease, and vitamin K deficiency. There's only about 3 things that will cause an elevation in both the PT, PTT, and the platelet count is going to be normal. There's only 3 things that do that: liver disease, vitamin K, and DIC. Now, liver disease and vitamin K have the same exact type of presentation with clotting factor deficiency type of bleeding. And often, they both have a greater elevation in the prothrombin time than they do of the PTT. So therefore, it's just one of the clues because factor 7 is eliminated first. Now, you cannot distinguish these clinically too well, although liver disease should also have increases in the transaminases. The problem is that this is not reliable because you could have a completely dead liver and have normal transaminases. The other thing is that it could have a low albumin, but the problem is there are other reasons to have a low albumin, such as malabsorption, malnutrition, and starvation, nephrotic syndrome. So it's not perfect. Ultimately, the only way to tell these apart is just to give vitamin K. If the person gets better, then it was a deficiency. If the person is the same, then it was liver disease. If the person has major bleeding from either one of these, what is the treatment? Can you tell me, please? If they're bleeding, give fresh frozen plasma. Why not use vitamin K if they're bleeding? You will use vitamin K. It's just if they're bleeding, fresh frozen plasma works as soon as you put it into the body. So therefore, fresh frozen plasma works faster. Now, got to go to one other part of the notes. And that is, let's take this person here and make it a 66-year-old, 76-year-old guy with a history of prostate CA, prostate cancer. And this guy is going to get a prostate biopsy, and he is found on routine screening, to have an elevated PTT and a normal PT, but he says he has no history of bleeding. No bleeding. What's the diagnosis? He said no bleeding? Yeah, no bleeding for sure. Could be factor 12 deficiency. Could be factor 11 deficiency. Could be factor 12 deficiency. He says that he is gravida 12, para 0, 0, 12, and 0. 12 abortions. Ugh, spontaneous, I hope. By the way, he also says that he has a history of 3 deep venous thromboses and 2 pulmonary emboli. What is the diagnosis? The answer is multiple clots with an elevated PTT. Multiple clots with an elevated PTT is a lupus anticoagulant, because only the lupus anticoagulant gives you an elevated PTT. Look up, look up, look up. Why isn't it protein C and protein S? Because protein C and protein S deficiency don't make abnormalities of the PTT. Now, the other clue for the lupus anticoagulant and the anticardiolipin antibodies is the multiple spontaneous abortions, or a positive VDRL. The multiple spontaneous abortions. Spontaneous abortions tell us that it's most likely to be anticardiolipin antibodies, lupus anticoagulant, because the 2 antiphospholipid syndromes are lupus anticoagulant and anticardiolipin antibodies, and they're associated with multiple spontaneous abortions. Now, what if we take out this part and simply say we got a guy who's got a normal PTT, no abnormalities, but just has increased clotting? What's the most common cause of thromboses that are unprovoked? What's simply the most common cause of a hypercoagulable state? There's nothing special about it. The PTT is normal. The answer is the most common cause of a hypercoagulable state, thrombophilia, is a factor V Leiden mutation. Factor V mutation. And simply by statistics, the factor V mutation is the most common cause of thrombophilia. However, the only cause of thrombophilia that gives an abnormality in the coags, PT-PTT, is the lupus anticoagulant. How do I recognize the antithrombin 3 deficiency? It's the opposite of a lupus anticoagulant. It's a person who has a normal PTT. You bolus them with heparin, but it won't go up. You bolus them with heparin, but it won't go up. It's the opposite. It's the person with the normal PTT that won't go up in response to heparin. That's an antithrombin 3 deficiency. Protein C, protein S, factor V Leiden mutation. There's nothing particular for protein C and protein S deficiency. Factor V Leiden is statistically the most common. Lupus anticoagulant is the only one that makes the PTT elevated. And antithrombin 3 is the opposite. It's a low PTT that you can't get it up. This is a high PTT, you can't get it down. There's a low PTT, you can't get it up, and statistically factor V Leiden mutation is simply the most common. The clotting cascade is an example of the part of the human body filled with intense balance, beauty, competition, and the sense that each part is working together so that you neither bleed nor you clot. It's a very Taoist experience, I think. I wish you well. Are we at the end of hematology already? Oh, I wish that it could go on forever and that we could be together forever. However, it's not so for this case anymore. I wish you very well. Remember, Aristotle says the greatest or chief part of courage is endurance, as it says in the introduction, my little love letter to you at the beginning of this book. Look at the preface. And that means that individually it's not complex, but it is finding the emotional endurance simply not to stop. Do not stop. Even if you think you are wrong, it is said, the fool who persists in his folly will become wise. Do not stop. I wish you well. Farewell.